og velkommen. Vi så glad for at dere har kommet opp her til Eitri og skal være med på dette arrangementet om eksport av helseinnovasjoner. Mitt navn Tone Skår, og jeg leder av avdeling Vestland her i Norwegian Smart Care Cluster. Jeg har med meg Ingrid, som kommer fra Designerbyråen Bergen, og Torleif står der borte, som leder av Eitri medisinsk inkubator. Vi synes det kjempegøy at så mange har meldt seg på. Det et fullt arrangement, og gleder oss til å dele kunnskap, nettverk og få til samhandling her i dag. Jeg vil bare si kort om Norwegian Smart Care Cluster. Den startet i Stavanger. En nasjonal klynge. Vi bygger opp noder her og Stavanger og i Agder, og sprer oss nå, men medlemmene fra overalt. Og det handler jo da om å ha med akademia, om å ha med helsevesen, om å ha med investorer og myndigheter og brukere. Ikke minst brukere. Det handler om pasienter, pårørende og de ansatte i helsetjenestene. Og hva skal til for å få helseinnovasjoner til å komme utenlands? Kanskje design et veldig, veldig viktig element, om å designe for brukeren. Så dermed så skal du, Ingrid, få lov å introdusere den første som skal snakke og dele sine historier. Velkommen.
Takk, Tone. Jeg må bare støtte det Tone sier. Helse og design kjempespennende. Og jeg synes jo det ekstra spennende her i Bergen, fordi ikke bare har vi veldig sterke innovasjonsmiljøer innen helse, men vi har også et veldig solid designmiljø her, med mange internasjonalt anerkjente designere. En av de skal dere få treffe her. Det Tom Morgan, som kommer fra Anti Bergen. De har jobbet i 6 år med et case som heter When It Solve. Tom, vil du fortelle mer?
Takk. Thanks, Ingrid. Okay, well, it's great to be here. I've been told I've only got 10 minutes. And I could probably talk about this for a day, so let's get going. Just want to start by introducing who we are and what we do.
This museum is like a dream, but the dream was real.
So it could be that we're seeing that we're not the normal sort of service provider to the healthcare sector. That's kind of the point. So this was the title of the event, as I received on an email, and I believe it's my job to say that this shouldn't be a question. How important is design? So the story that I want to tell you about is one that's very Norwegian, even though the team that worked on it was international, but it was entirely created in Norway, and it's designing for human factors in response to an overdose. And this is Norway as a world leader. So this story is about a small pharma company in Oslo, a small team of scientists in Trondheim, and a small team of designers in Bergen. A life-saving product that was launched last year, used over 600 times in the first 6 months alone on the streets of towns and cities across the country. 7,000 units are now in circulation, approximately in the Nordic countries. So this is already an export. With 15,000 produced, launching in the UK and around the world this year and onwards. It's a simple solution that has shifted, I got to stand on this side, drug addicts into lifesavers. So the question that we had to address was, what's the best design solution that captures the core qualities of a life-saving product for some of the most vulnerable people in society? So these qualities are that it has to earn trust. Right? It's guaranteed to be the same no matter where you are, where you find it. This is the same. So there's kind of qualities that you find in Coca-Cola. It has to be a product that people carry with them that doesn't carry stigma. Right? This doesn't make them feel like a victim, or it doesn't make them feel sick, but actually this is a product they want to carry. Coloplast is a fantastic example of a company that does that. That's a catheter in a lady's handbag, a Danish company. That easily identifiable and easy to find, of course. It's a life-saving product, and obviously one that it's intuitive to use. It's very easy, 0 barriers to saving a life. The product's got to help, not hinder.
Med annen rus har ført til mange overdosedødsfall mange steder i landet. Nå viser det seg at en nasespray har reddet livet til 600 rusmisbrukere så langt i år.
Jeg har i sekken, så det har alltid med.
Det er noe som er viktigere enn narkotika for rusmisbrukeren Jon.
Ja, vi har 2 sprayer. Så eventuelt overdoser av morfin eller heroin.
Dette er en livreddende nesespray som rusmisbrukere i 55 kommuner over hele landet har fått utdelt. Nesesprayen Naloxon inneholder en
We are in an opiate crisis. It's an epidemic in the United States. Up to 75,000 people die of overdose each year. Just a few years ago, you had to call the ambulance and they can come and inject naloxone to save people's lives when they have an...
Standard pharmaceutical packaging is not innovative, and it's not really dedicated to our user group. So for that, we realized that we have to think out of the box, and that's how we came into contact with Eitri.
It's not just comfortable to carry in your hand and in your pocket, but also one that doesn't carry stigma, like so many pharmaceutical products do. And of course, it also has to be intuitive and easy to use in a high-stress life and death situation.
So we've all come across in our life products, healthcare products, care tech. It's a modern term, but we've come a long way from the horror aesthetics of the history of medicine to where we are today. But we have all come across products or experiences of healthcare which aren't really for us. They're not talking to our soul, if you like. Right? They're not full of care and compassion. And it's a fundamental problem with my industry as a responsibility to the world, right? Because design is often associated with the wealthiest and healthiest in society. And there are qualities that we use for consumerism that make us feel good and drive behavior in a way that we want them to, people to behave in a positive way for Apple, but not maybe a positive way for themselves. And so there are tools out there, there are methods, we are all of us, very aware of them, and yet it's not really something adopted widely enough in healthcare. And that's kind of ironic, right? Because we all know that the bedside manner, whether it be your mother or a nurse or a doctor or any care professional or someone who's looking after you, is potentially one of the most powerful things about being ill or in need of help. And maybe it's a placebo in part, but I love placebos because they're very cheap and there's no side effects. So if they work, like, let's use them. Healthcare is also something that is no longer just confined to the professional environment. We have to think, just like Ventazolve, this is for the streets. This is in a chaotic, low-light, mad environment quite often. And so that's kind of where we are responding now. We're not just thinking about triage in ICU, we're thinking about triage on the streets and in the home. So Ventisov, as a Norwegian story, has, this is an article about it in Fastco, Design Week. It's had a huge amount of publicity and interest around the world. Inside the Nordic countries, it's a political conversation, of course, but people just take it as something quite ordinary. Why shouldn't people who are opioid dependent be at the centre of conversation in a political debate? But when talking to colleagues in the United States or journalists or museum curators, they think this is unreal. This is crazy. This is the ultimate kind of thing you'd imagine to come from Norway. Right? So Ventisov's also going to be, as a Norwegian pharmaceutical product, it's going to feature in the Design Museum of New York at the Smithsonian in an upcoming exhibition at the end of this year and half of next year of design creative responses to epidemics. So that's really cool. It's only been on the market a little bit. It's a pharmaceutical product. They're normally not sexy, not enough to get in a design museum. Right? But this is. But this got me thinking about the epidemics point. So we are living through modern life of which is causing, or we are discussing, a mental health crisis right now. We are in an obesity epidemic. We are in a diabetes epidemic. We are in an opioid epidemic. And of course, we're in a COVID-19 epidemic. So the curators of this exhibition have really got me thinking in regards to all of the things that we need to address and design for. And what we know, all of us right now, because there's Antibac and Munbin here, and you're all sitting in a kind of peculiar way, right? Very antisocial. We know that every crisis or epidemic is won or lost on human behavior. And design is fundamentally a response to human behavior. So if design is a synergy of art and science, right, it's all about framing those constraints. And these constraints they're human, they're constraints of knowledge, they're constraints of finances, they're really practical. They're social and political and cultural constraints that we have to balance. And that is the same as medical regulations and the boundaries of science that you guys are all testing. Good design is about pushing these constraints in a positive way. And rules are there to be broken. This is one of the things that we have found with Ventisov, is that actually what we did was against the rules on the face of it. But when challenged, we realized it wasn't against the rules. It's just that there's a culture of kind of that's the way it's always been. Right? So the paradigm changes, but often we kind of continue to develop in the old paradigm, because that's just the way it's always been. So it's about moving away from it has to be that way to challenging that assumption and saying perhaps there's another way. So what does design bring to healthcare as a story here? So first of all, it's bedside manner, like we discussed, this idea that care and compassion in a product or an environment is really important. Compassion and empathy, and these are top priorities for healthcare solutions, because design is a fundamental response to human behavior. The second is to challenge the status quo. So this is moving from, obviously, that's just how it is, right? It has to be this way, to perhaps there is actually another way of doing this. So for example, when Ventisov has gone through to regulators and addressed every single concern, and of course been approved at the highest level, our questions were always like a petulant toddler, why? Why does it have to be like that? And if you ask why often enough, you'll realize people don't know. Early stage professionalism and clarity. This is also a startup incubator, right? So you're not just dealing with life science, you're also dealing with partners and investors. And this is a really important point from the industry point of view. Having early design qualities in a company is about giving strategic direction to where you're going, understanding the user group, simply just being a better professional. And finally, it's the competitive advantage, because healthcare is becoming democratized. like I said, it's no longer confined to just the professional environment. Patients make choices. At the most sophisticated level, patients make choices about what happens to them in the operating theatre. So of course it's competitive. in state healthcare, it's still highly competitive. So where's a good place to start? So Ventazolve, like a great many contemporary health innovations, considers self-care and empowerment. This is a life-saving product that's put in the hands and pockets of people who are living on the street or suffering from opioid dependency, the type of people cross the road from sometimes. Now they're superheroes. They're saving lives. And it's about looking at where they are, not just giving that power to first responders. So I want to leave you with this as something that I'm really inspired by. This is about every hour. I stole this from a German academic. This is every hour in a year. So chronic care is mostly self-care. So this is, for example, right? Let's take diabetes, one of the epidemics we're dealing with at the moment in the world. So this is the number of hours a patient with diabetes spends with a doctor versus the number of hours where the patient is alone with their chronic condition. So that's the design opportunity. That's it.
Thank you, Tom. And I know it will be a panel afterwards, but just one final question to you before we leave you. In the Ventazolve case, you came in the very beginning.
Yeah.
How important would you say it is to get started early versus later on?
Well, I mean, we couldn't have done what we did if it was later on. And we couldn't ask that why. So many decisions would have been made beforehand. It's not in that case, it's not actually our success. That's the success of a company that has thought, like you saw the lady, Nina, said, early on, they knew that they couldn't use pharmaceutical packaging out of the box, off the shelf solution. So they had to challenge that. So it was their vision that sort of was the success of getting us early on. Yeah.
Exciting case anyway. And then we move on to a different exciting case. I've been looking forward to hearing from you, Roald Kvam from Motitech. Welcome to the stage.
God morgon. Jeg heter Roald. Jobber som Chief Strategy Officer i Motitech. Og nå skal vi ut på en liten sykkeltur fra beste byen Bergen. Vi skal ut i Norden, vi skal over til England, Kanada og tilbake igjen på 10 minutter. Og vi skal se på hvordan du kan motivere mer enn 4000 beboere ved sykehjem, dagsenter, seniorsenter i 7-11 nasjoner til å sykle 2,5 ganger rundt kloden på 4 uker. Det helt mulig. Motitech det startet i 2012. Det var ikke vår idé. Det var etat for alders- og sykehjem i Bergen som ønsket å få opp fysisk aktivitet blant byens beboere på sykehjem. Så de kjøpte inn en serie med ergometersykler der du kan sitte i en vanlig stol eller rullestolen din, trille inntil og komme på en sykkel som har hjelpemotor både på armene eller også på beina. En god idé. God intensjon. Det var det at folk er folk. Uavhengig av alder og funksjonsnivå så er det møkt kjedelig å sitte og trykke på en ergometersykkel. Minutt etter minutt eller time etter time. Så det funker dårlig. Spesielt var det vanskelig for personer med demens å stå gjennom økta eller repetere den. Det skal så lite til før du får en fokuscue som bare tar hele fokus vekk, og så vil de av. Så går det ikke. Da koblet de oss på, som den gangen var et filmselskap. Hadde gjort noen jobber for dem på infofilmer, opplæringsfilmer, liksom den biten. Og på den tiden så var det ganske populært i Norge med sånn minutt for minutt-film. Vi har jo tatt toget fra Bergen til Oslo, tunnel for tunnel. Vi har tatt hurtigruten 11 døgn oppover. Og vi har sørg meg sang gjennom salmeboka, sang for sang, hele denne nasjonen her. Og vi har sittet på lille julaften og sett ribba steika i 7,5 timer til den poppa. Altså, vi har jo en lyte. Men det vi gjorde var at vi lagde 4 enkle løyper fra Bergens gate. Som om du på sykkeltur. Rolig, behagelig bevegelse. Så la vi på musikk som vi tenkte bergenserne kan like. Og det ser sånn ut når det blitt litt videreutviklet. Dette fra The Times sak på oss i England.
Every day when she's been on the bike, she tells you about somewhere else she's been. California, Switzerland, Singapore, Rome, Israel.
This is Jean. I'm parked your bottom here.
All right, my love. Okay.
We're going to go to Hong Kong today. How about Italy? Italy.
Yeah, that's fine. Right, we're off. Okay. I come up here to do 30 minutes and they put the film on and each time I try and do more. I want to tell the people to get out of the way. They come.
When coming into a care home, typically people become very inactive. The inactivity would be the reason for rapid health decline, more than actual age itself.
Judith, make sure he behaves himself now. Something is fine.
A piece of technology like this will really help in terms of exercise. So exercise is generally going to be good for keeping your limbs moving.
It's been really extraordinary to see my mother change because 3 years ago she was pretty much bedridden, and to see her now exercising on a daily basis like this is extraordinary.
I was in a wheelchair at one point, then I graduated to the next thing it'd been the marathon.
What really makes this different is that the videos in front of the bike is actually the key here. We build a video library, almost like a Netflix model, so people could choose go traveling or they could find their local memories.
I'm seeing places that I should never go to, which makes it even more interesting.
You can visit places where they were born, places they might have visited as a child, and obviously then they engage in a conversation.
This is really important for a resident with dementia, being able to go back in memories, revisiting places.
The cycling initiative created by Motortech is a great piece of technology that helps those with dementia. At AXA we run the Health Tech and You Awards, and last year we had 2 incredible winners in the category Innovations in Early Diagnosis of Dementia. All of the innovations we're seeing in dementia care are really exciting and will go a long way to improving the lives of those living with the condition.
Do you remember about Motherhood?
Nice, actually.
Yeah, lovely being. Yes. When I met Anne, she was a very, very scared lady. Not great at making friends. So when we introduced Anne to the bike, it was like seeing a different lady. Did you ever used to walk down this road? Did you? Such a massive change in her confidence. She just can't wait to get down here and then mix with the other residents as well, which 3 months ago, I would never have believed.
Oh, well done. We've reached the plan.
Even residents that I thought would never ever dream of getting on this bike are actually enjoying it, which is fabulous.
This is keeping me in trim, but I haven't done much today at all. Been chatting too much.
I Bergen så gjorde de et pilotprosjekt på 5 institusjoner, også langtidsavdeling for personer med demens. De kjørte døgnkontinuerlig adferdsregistrering, 1 måned uten sykling med motivy og 2 måneder med sykling. Og de ønsket å se om syklinger hadde noe effekt på mer enn akkurat økta, men døgnet rundt. Og om det hadde effekt på fallforebygging spesielt. Vi har fått lånt skåren fra Bergen, og her ser dere dette er ren, god livskvalitet med forsvinnende enkel, irriterende enkel innovasjon fra Bergen. Men det funker, og det er designsuksessen vår. Gjør det enkelt, brukersensitivt og stå ved det. Vi begynte med 4 løyper på 2 DVD-er. I dag så har vi nær 2000 løyper fra 40 land, og vi lager 300-500 nye filmer hvert år. Og det vi gjør er at vi kan skreddersy det til der brukerne har sine minner. Enten der de har bodd, eller der de har barnebarna sine, eller der de har jobbet, eller der de har ferieminnene sine. For når du fanger minnene deres, så har du motivasjon til de første metrene, og mestringen tar de videre. Vi en av 25 eksempel til inspirasjon, som det heter, i Leve hele livet-reformen til regjeringen. Kvalitetsreform for de eldre. Det vi ganske stolt av. Vi har et 2 års forskningsprosjekt i Kanada. Hvis dere husker i panelpraten og spørre meg hvordan vi lander der, for hele poenget her jo hvordan kommer vi ut, så var vi en slipsknute unna ingenting. Vi har hatt et svært prosjekt i England, Sport England sin Active Aging-kampanje. Vi var det eneste utenlandske selskapet som fikk støtte. Jeg tror ikke de hadde tenkt at noen utenlandske selskap skulle søke. Og de hadde ikke koder for å kunne gi oss penger, for de kunne kun gi penger til engelske selskap. Så da måtte vi etablere oss i England for å få løst ut de midlene. Så vi kjørte et 2,5 års prosjekt med 25 institusjoner i England. Da har du plattformen, landingsplassen, for å komme til England. Så det var en gave til oss, og litt sjokk for deg. Vi tilbake i Kanada. Vi har et prosjekt som går nå, der de tar filmene våre vekk fra sykkelen, tar med seg PC-en eller nettbrettet inn til de som i palliativ omsorg, og deres pårørende, for å se hva effekt har disse filmene for de som i en sånn fase av livet. For det som ofte skjer at de stilner, går inn i depresjon og forskjellig, men de trenger, og de pårørende trenger, å få prosessere livet akkurat da, det siste stykket. Pilotprosjektet der i 2018-2019 ga ekstremt sterk score, så vi gleder oss til resultatet der. I 2017 var det sykkel-VM i Bergen. Det gikk jo ikke godt økonomisk, men vi lagde en folkefest. Og da tenkte vi, søren heller, vi lager verdens eneste og første sykkel-VM for eldre og personer med demens. Og det har vi fortsatt med. September måned, hvert år, så det sykkel-VM. Her scoren fra 2019, 4 uker, 7 nasjoner var med, 200 lag, 108 000 kilometer, 4.333 deltakere. Her kols, demens, Parkinson, amputasjoner, det oksygenflaske, det utagering, det angst. Det hele bøtterballetten, helt vanlige beboere på sykehjem. Og det ser ut sånn som dette. Helt vanlig sykehjem. Fantastiske folk.
Have you seen the wording on the front of your t-shirt? No. Pedal on, man, pedal on. I was 100 in November, so I'm 100 and a half. This is a damn good idea. It's exercise and it's good for you. You know, otherwise what would people do? You know, they don't go out walking so much, but when it sits on here and get exercise, it makes it more interesting.
We entered the Road World Seniors last year and we came 13. And the atmosphere was amazing. The residents wore t-shirts and caps and got into the spirit of it. It's one of the best things we've ever done. The residents love it, the staff love it. It's amazing.
It's not just the physical outcomes, it's much more than that. What I found absolutely fantastic is the videos and the sceneries that people can engage with and the music that's playing. So there's multi-sensory elements to it that will help anybody engage and generate some benefit.
Her ser dere reisen vår. Bare lander det med noen læringspunkt. Legg merke til at vi henter ikke inn investor før etter 5 år. Det var viktig. Vi hadde kontroll på det vi gjorde selv i 5 år. For oss var det viktig. Det prosjekt som tok oss ut, prosjekt som tok oss ut, og prosjekt som tok oss ut hit. Vi brukte det som landingsplattform for å komme ut internasjonalt. Lykkes i prosjekt, gjør det ordentlig. Det har vært en suksesskriterium for oss. Vi startet i ordentlige omgivelser, med ekte mennesker, ekte brukere, med ordentlig problem. Vi fikk lov til å komme inn på avdelingene i Bergen by, og skape prototypen sammen med de som skulle bruke det. De de virkelige designerne her. Vi har bare lyttet og prøvd å lye. Vi har levd lenge på å fortelle deres historie. Vi har fått kjeft når vi har vært på pitchekonkurranse, fordi vi ikke har fortalt om teamet vårt, og pengene våre, og produktet vårt. Vi har fortalt hva produktet gjør, hva effekt det har i deres liv. Det har vi holdt på med, og det gjør vi ennå, selv om vi får kjeft. Men så har vi etter hvert lagt på det vi kaller third voice of value, altså forskning. Harde data. Og det må du ha, hvis du skal lykkes internasjonalt. Så det jobber vi også med. En utfordring å gå når vi sosiale entreprenører. Det betyr at vi bryr oss om store samfunnsutfordringer. For oss det eldrebølgen. I dag er vi 650 000 over 67 år. Om 15 år cirka så vil det være 1 million. Det kan knekke hele velferdsstaten vår, hele velferdsordningen vår. På 15 år. Den bølgen vi nødt for å håndtere, og vi nødt for å håndtere den bredt og i lag. Og for oss det kjempeutfordrende, for når vi hører en oppe på Hitra som trenger hjelp, så reagerer vi, og så går vi gjerne fort inn. Men hvis vi skal nå 1000 og flere nasjoner, så vi nødt for å legge noen skylapper på vi, for å ikke nå færre, men nå flere. Og det gjør vondt for oss, fordi vi vet hva dette betyr for de som får komme til sykkelen. Men det må vi, hvis vi skal komme videre ut. Eldrebølgen vår mulighet og vår utfordring for vår del. Vi det ikke alene, vi striler på tur, sier vi. Vår gründer motorsykkelmekaniker. Og det håp for alle. Vi har ikke peiling på helse, men vi kan stille spørsmål, og vi kan lytte, og så prøver vi. Vi spør oss fram. Og vet du hva, folk elsker å fortelle hva de gode på. Så vi spør oss fram, og så bygger vi community. Ikke nettverk der vi nyter godt av deg alene, men der vi også gir inn. I England så det for eksempel sportsdepartementet som gir oss støtte. De gir oss funding. Ikke helsedepartementet. Jeg synes det kjempekult. For de skjønner hva dette Til slutt, sykkelvert. Vi har et veldig enkelt konsept, men det skaper nye ideer rundt. Så i Arendal så hadde de for stor trøkk på syklinger til å kunne ta unna håndtering av det. Så de hentet inn nye landsmenn som hadde fått språkopplæring og trong mengdetrening. De fikk komme inn på byens sykehjem og være sykkelverter, og hjelpe særlig under måltid og sykling. I Bergen tok de det videre, så her et sykkelvertprosjekt i byen vår, med utspring fra Fantoft. Og de tar ikke inn bare våre nye landsmenn, men også droppet fra skole eller fra arbeidsliv. Folk som faller ut av arbeidsliv og ikke helt finner veien inn igjen. De får komme og være sykkelverter. Her har dere noen kull av sykkelverterne. Vi fikk julekort av dem. Dette ikke færre varme hender. Disse kommer i tillegg til den poolen av frivillige som ved sykehjemmen allerede. Og dette fødes ut av enkel velferdsteknologi fra Bergen og Norge. Det vi stolt av. Da sier jeg takk for meg.
Tusen takk, Roald. Mens Paul Johan rigger seg til, så vil jeg bare låne deg bitte litt.
Du skal låne meg bitte litt.
Låne deg bitte litt. Nei, for det som utrolig spennende, du skal jo delta i en paneldebatt, men jeg må få stille deg litt spørsmål før du drar. For det som jeg synes spennende med caset ditt, det at du jobber på akkurat samme måte som designerne. Ved at du setter brukeren i fokus og spør hva vil de, og så bruker du det som brekkstang for å lykkes med innovasjonen din. Men har dere jobbet med designere underveis i prosessen, eller dette her bare naturlig for deg å jobbe på den måten som en sånn DNA?
Jeg skal i hvert fall ha det rett på CV-en min, at jeg jobber som designer nå. Det var ikke klar over. Nei, altså vi har hatt det inne, men da gikk det mer på brandet vårt, på oss som selskap.
Ja.
Og så har vi inne, jeg vet ikke om dere så det, men nå har vi startet et 2 år langt prosjekt på produktutvikling og impact management. Og til produktutviklingen vår nå så skal vi ha inn flere nye funksjonaliteter, og så gå ut mot konsummarkedet. Og det betyr et helt annet design, både på produkter og løsningene, og på oss som selskap. En helt annen måte å jobbe på. Vi skal ikke slutte med det vi driver på med, men vi skal utvide. Så der får vi hjelp.
Ja.
For vi eier ikke hele vetet, noen av oss.
Nei, spennende. Nei, men jeg gleder meg til å følge videre med på dere. Det sikkert om 5 år. Hvor mange flagg har du på kloden da?
Det sykkel-VM måned nå. Vi har 11 nasjoner med. Det en ny rekord for oss. Og de ligger an til å sykle 3 ganger rundt kloden. Hvis de holder oppe helt i mål. Så det veldig gøy.
Veldig bra. Tusen takk til deg. Vi fremdeles innen helse, men nå skal vi inn til en helt annen del av helseverden. Pål Johan Høl fra Biomatlab. Velkommen på scenen.
Jo, takk for det. Jeg forsker og leder av Biomatlab, som nabo med Eitri. Veldig glad for å bli invitert. Vi holder til i labbygget rett ved siden av her i 7. etasje. Biomatlab har som formål å gjøre forskningsbaserte vurderinger og oppfølging av medisinske biomaterialer og klinisk praksis. Vi et samarbeid mellom ortopedisk klinikk på Haukeland og Universitetet i Bergen ved Klinisk institutt 1 og klinisk odontologi. Jeg tenkte jeg skulle vise deg noen forskningsspørsmål som vi har jobbet med de siste årene. Jeg må skuffe dere og si at jeg har ikke noe nytt produkt å vise dere. Vi jobber mer på ettermarkedet, kan du si, og prøver å fjerne heller dårlige produkt til det beste for pasienten. Her en artikkel vi publisert i tidsskriftet for den norske legeforening nå i år, der vi så på metallfrigjøring fra metall mot metall hofteproteser. Så det vi undersøker her å finne ut om metallfrigjøring fra denne protesen da skadelig for kroppen. Fordi at internasjonalt så ble det funnet rundt 2010 at kobalt- og kromfrigjøring fra dette implantatet ga systedannelse. De kalte det faktisk pseudotumor rundt leddet da. Så derfor så slutta de fleste land å sette inn dette implantatet i folk rundt 2012. Da hadde vi allerede startet denne studien og skulle prospektivt følge disse pasientene. Og de har vi fulgt i 10 år nå og måler de jevnlig med hensyn til disse metallionene. En annen case vi ser på det hvorfor disse protesene løsner og gir vevsreaksjoner og beinebrytning. Når vi bruker protesen eller går, da, så blir det produsert veldig mye slitasjepartikler. Det kan være alt fra mikroplast til metallnedbrytningsprodukt, som ender opp i vevet rundt protesen. Og det kan føre til en inflammasjon som gir en kaskade av hendelser som kan føre til beinebrytning. Du får dannet litt for mye osteoklaster som bryter ned skjelettet rundt protesen, som vi ser på røntgenbildet her, i mørke feltene. Vi ser også på sementeringsteknikker for, i dette tilfellet da, kneproteser. De også kan dessverre løsne fra leggbeinet da. Så i dette tilfellet så har vi prøvd å simulere gange i en testmaskin, og vi måler da hvor mye protesen beveger seg i løpet av mange sykluser da. Og så tester vi ulike sementeringsteknikker og ser hva som den mest stabile teknikken da. Og her ser vi en forskerlinjestudent, Michelle, på labben, som involvert i dette prosjektet. Hun har også laget en spørreundersøkelse blant alle Norges ortopedkirurger for å høre hva klinisk praksis de utfører. Oppdager at det ganske stor variasjon i praksis der ute. Så vi prøver jo da å finne best mulig praksis, så vi kan levere tilbake igjen til landets kirurger. Og så har vi en plastikkirurg som vi samarbeider med, Eivind Strandenes. Han undersøker hva den beste suturteknikken for håndsene. Det tester vi på labben da. Han har testet veldig mange teknikker som vi nylig har publisert her i 2 arbeid. Nå har han nettopp søkt Helse Vest om et PhD-stipend, der han ønsker å teste både på lab, men også i en klinisk studie da. Beste mulige rekonstruksjon av avrevne leddbånd, også i håndledd. Så en hovedaktivitet for labben vår har vært å se på leddproteser i ortopedisk kirurgi, fordi at så mye som hver tredje person over 65 år har slitasjeforandringer eller artrose i leddflatene sine, både i hofte og kne og i andre ledd. Så jeg tok med et bekken og en femur i dag. Og hvis du har artrose, la oss si, i hofteleddet, så vil da kirurgen fjerne da den skadede brusken. Han vil gjerne kappe av leddhodet, og da erstatte det med en protese, en hofteprotese, som blir satt inn i marghulen her. Dette er den mest brukte hofteprotesen i Norge i dag. Den kan faktisk festes direkte i bein, uten noe sement, som tidligere har vært veldig vanlig å bruke til å feste metalloverflaten med. Så den er coatet med en veldig beinvennlig hydroxyapatitt, som beincellene da liker og gror fast i. Så har vi da et kuleledd av koboltkrom, som beveger seg mot en plastkopp, da, polyethylen, som blir satt inn i bekkenet sånn. Og så beveger det seg på denne måten. Her har det skjedd en del produktutvikling heldigvis de senere årene, fordi plast er jo ikke så veldig slitesterkt. Men der har en funnet nye teknikker nå for å kryssbinde disse polymerene i plasten da. Så nå slites de kanskje bare 10% av det de gjorde for 10 år siden. Det er gjort 16 000 leddproteseoperasjoner i Norge per år. Mest hofte, men kne er veldig stigende. Men dessverre så utgjør reoperasjoner 14% av alle operasjoner i Norge. Så målet vårt er jo da å få ned antall reoperasjoner. Den viktigste årsaken til reoperasjoner, det er materialsvikt. Det er løsning, det er fraktur av komponentene eller beinet, og det er smerte gjerne. Så i 2007 så dannet vi en retrieval-bank der vi samler, ja, sånn kan det typisk se ut på et kontor til noen av ortopedkirurgene på Haukeland. Vi begynte systematisk å samle da forskjellige design i samarbeid med Nasjonalt register for leddprotese, som ligger her i Bergen. Og vi har samlet materiale fra over 200 pasienter som vi har analysert og prøvd å finne ut årsaken til svikt av disse materialene her. Og så har vi fått dette publisert, og alle disse produktene er nå ute av markedet. Og vi tar litt av æren i hvert fall til det. Innovasjon, det er jo tema her i dag. Jeg må nesten innrømme å si at det er relativt lite nyskaping innenfor dette feltet. Det er veldig tradisjonelle materialer. Det er stål, det er koboltkrom, det er titan. Så her er det egentlig rom for mye utvikling. Det nasjonale leddregisteret som jeg nevnte, de har også en litt sånn konservativ holdning ved at de sier at et produkt bør ikke introduseres i Norge før det har vist 10 år med gode resultat. Så da må vi gjerne vente på utlandet at de har vist at dette produktet er bra. Så derfor tar det lang tid før det blir introdusert i Norge, og det fremmer jo ikke akkurat innovasjon. Nylig så har vi kommet i kontakt med noen partnere på fysikk og teknologi nede på høyden, som kom til oss og sa at de hadde utviklet en metode for å produsere diamant, kunstig diamant, som de lurte på om vi kunne coate disse hofteprotesene med. I stedet for denne hydroxyapatitten. Og de mente at det materialet kanskje har enda bedre egenskaper enn dette mineralske materialet. Det veldig slitesterkt og sannsynligvis veldig vevsvennlig. Det jo karbonbasert. Så det går vi nå I gang med å teste ut. Det blir veldig mye, selvfølgelig, basal forskning I starten. Og vi håper jo da at kanskje Eitri kan være med oss og hjelpe I gang denne ideen. Det hadde vært kjekt. Det var det jeg hadde tenkt å si om det. Takk.
Tusen takk til deg. Kjempespennende. Og det som jeg synes som som står utenfor helsebransjen skal vi se, Øystein Ødegård, vil du begynne å gjøre det klar? Det som jeg synes spennende når jeg står litt sånn på siden, det jo det du inne på slutten der, hvor konservativt det I bransjen, og hvor strengt det og hvor opptatt alle av å følge reglene. Og kanskje hvor viktig det å være litt sånn bergensk og spørre, ja, men må det være sånn?
Jeg glemte å legge til at vi med på en del randomiserte kliniske studier.
Ja.
For det en måte å få introdusert nye produkt på før det har gått 10 år. Så vi med på 4 studier der vi sammenligner et eksisterende, velfungerende produkt med et helt nytt produkt på markedet.
Ja.
Så på den måten kan du lure det litt raskere inn. Ja. Så det jo det fremmer innovasjon, kan du si.
Ja.
Det blir gjerne sponset av industrien, da, altså de som produsenter. Ja.
Ja.
Men det blir gjerne gjort på små kohorter da. Så resten av landet må vente på at de produktene validert.
Ja. Så for designere som skal inn I deres bransje, så må vi ha med en stor dose med tålmodighet og ja.
Ja da, men samtidig får du veldig trygge materialer, men du får kanskje litt gamle produkt. Det får du.
Ja. Spennende, men tusen takk. Vi skal videre I programmet. Siste mann ut, det Øystein Ødegård Olsen fra Aupena. Her gikk teknikken som en kule. Kjempebra. Velkommen.
Hei. Jeg heter Øystein. Aupena, det gründerselskapet mitt. Jeg leder av Aupena. Jeg har med meg vi totalt 6 stykker. Vi har laget en sensor for overvåkning av pustefrekvens. Pustefrekvens det vitale tegnet som endrer seg raskest ved sykdomsutvikling. Altså en tidlig indikasjon på at noe I gjære. Det interessant å bruke til, det var nevnt sånn diagnostikk på hjemmefronten, for å se om man måler temperatur, men det også interessant å på en måte ha noe mer beslutningsstøtte. Og så brukes det I sykehus og på legevakt. Jeg jobber på legevakt, jeg jobbet I natt. Der måler vi også pustefrekvens. Sykepleierne gjør det manuelt ved å stå og se og telle på pasienten og føre det på papir. Det innovative her, på en måte å løfte det og gjøre det anerkjent rundt I Norge og verden. Ideen kom I 2015, vi startet selskapet I 2016. Nå I dag det 2021, så det tar litt tid. Vi har gjort markedsundersøkelse I Norge. Vi har utviklet en prototyp som vi har testet I et pilot på Universitetssykehus I Tromsø på friske personer, opp mot gullstandarden på måling av pustefrekvens med veldig gode resultater. Her ser du gjengen, vi har også et rådgivende styre under, og vi har samarbeidspartnere I Innovasjon Norge og på teknologisiden. Her ser dere på bruksområdene på en måte tidlig indikasjon på livstruende tilstander og hjertestans og lungebetennelse og klinisk observasjon. I dag måles det manuelt, men vi vil over på den teknologiske siden og integrert I allerede eksisterende journalløsninger. Bruken tenkt I sykehus, legevakt og hjemmemonitorering. En stor pasientgruppe her kolspasienter. De bikker isbjerget sitt I 2025. Det en stor gruppe som har mye innleggelser. De har naturlig nok en høyere pustefrekvens enn det vi har, som ikke har kols. Litteraturen, altså vitenskap, forskning, sier at hvis man Hvis den pasientgruppen endrer pustefrekvens i 30% mer enn det de ligger på til vanlig, så det sidestilt med en forverring i sykdommen. Men vi har ingenting i dag som måler det. Så vi har ikke noen indikasjon på hjemmemonitorering som denne pasientgruppen kunne fulgt, og så kunne de tatt kontakt med fastlegen, med hjemmesykepleiere, et eller annet, for vi har sagt at nå har det skjedd en endring. Og da pustefrekvens det som endrer seg før temperatur, blodtrykk og infeksjonstegn. Og da kan man rett og slett forebygge sykehusinnleggelse. Igjen spare pasienten for en tur til sykehuset. Så det har på en måte treffsikkerhet på pasientsiden. Det til fordel for pasienten. Veldig mange som ønsker å holde seg unna sykehus. Og heller være hjemme og få behandling der. Kanskje tidligere behandling, slippe store mengder medisin. Og så har det innvirkning på klinikere, sånn som meg. Jeg lege, hvis jeg ikke nevnte det. Og det at vi bruker i dag veldig mye ressurser på å måle det. Det tungvinte systemer, og det kan man gjøre enklere. Og så har det innvirkning på samfunnet, ved at man kan gjøre disse prosessene mer kostnadseffektive og ressursbesparende. Markedet for sånn her type sensor vanvittig stort. Ikke bare i Norge, men i hele verden. Vi har en forretningsmodell med å på en måte kunne selge sensorer, antall sensorer. Kunnskapen i Ebnea ligger på teknologisiden. Vi per nå også 100% gründereit. Vi har holdt på i 5 år, vi ikke noen store investorer inne. Og det fordi kunnskapen ligger i selskapet. Sånn salgshjul produksjon og salg av sensorer. Vi har en målsetning om å være bærekraftig både i produkter som vi vil selge ut, men også i måten vi produserer på det, altså gevinstavtrykket mot miljøet. Så vi har en målsetning om at 30% av sensorene skal være gjenvinnbart. Det finnes konkurrenter i måling av pustefrekvens. Vi bruker akselerometer, som i alle mulige smartteknikker. Det ikke det geniale. Det geniale teknologien og måten å lese det ut. De ulike konkurrentene har enten en annen metode å gjøre det på, eller et annet bruksområde. Og det vi treffer på på en måte brukervennlighet opp mot pasient, kliniker og pasientsky. Ja. Vi har en målsetning om å entre markedet i 2022-2024, og så ekspandere ut. Vi holder på med spennende ting, blant annet teknisk utvikling og design. Vi holder på med sikre rettigheter. Vi har en regulatorisk strategi for godkjenning av et endelig produkt. Og vi jobber med markedsundersøkelse. Vi har på en måte en stor pakke vi skal gjennom. Vi har vært på Innovasjon Norge stipender. I går vant vi Vestlandets innovasjonspris for beste idé. Så det bringer oss videre på ferden for å nå målet om å få inn en investor og lage et kommersielt produkt. Vi jobber med FNs bærekraftmål som selskap, men også på produksjon- og utviklingssiden. Så det her det vi skal i gang med, eller sikre nå, det IPR, altså patentrettigheter, design og valg av materiale. Det var min korte lille pitch.
Ja, men kjempespennende. Jeg synes alltid det så kjekt å komme fra Bergen, for det så mye bra som kommer herfra. Av gode ideer og produkter, om det innen musikk eller helse eller design. Så men kjempebra og spennende å høre fra dere. Nå det sånn at vi har med oss Healthy Eats. Det hverken helse, eller jo det jo god helse i Healthy Eats. Ja. Dere det nye medlemmet til Norwegian Smart Care Cluster, og har med lunsj til oss i dag. Anniken, vil du si litt, skal vi hente mens? Nei. Jo. Ja. Ja. Du kan få si litt om dere, og så etterpå kan dere hente dere en salat, og så kan dere spise mens vi har paneldebatt.
So the first question is I want to ask to all panelists together. So in your opinion, how has the medical technology evolved in last 5 years? And how do you think it will evolve in next 5 to 10 years? So maybe more in your domain and like from the design perspective. So maybe we can start.
I think it's evolving fast. Apparently, some years ago, long time ago, it took 17 years from ID to come to the market on a health solution in the hospital, and we are trying to do that in half the time. So that's a goal, and I think further on it's going to be faster, more hospital working with innovation center like this, and people talks to each other, so the road isn't that far. So I think that's the right way to go.
We are in the aging well kind of sector or bubble, and there's a shift in how they understand health and how they understand aging. Is it going to be at a care facility or at home as long as possible? And if it's going to be at home, then they need all these devices, and they need to want to use them and be able to use them with less support of caregivers. So we need to speed up. As I told you, the wave of the demographic change can damage the whole system just in our country. So we don't have time for the long process. We have to speed up. And to do that, we have to make a teamwork of designers, innovation inventors, and academia and labs like this. So we are at the right place, but we don't have much time. We need to speed up.
Yeah. So I'm not sure. Maybe you should ask the audience. So if I press here now, hopefully something will happen up there, and we're getting a question up here. That is, we're basically now we've heard about medical technology today, a lot about what we have been hearing, but also pharma, drugs, using drugs, and I think also you are in the medical technology. Maybe you are also in the process innovation. Kind of different ways of working. And I'm wondering, asking the audience here, so if we are going to create an industry here in Bergen, being successful in medical innovation, where do you think we can have success? So we have 26 respondents now. That's very interesting. The shifting. It's super interesting. So I want to comment, because the biotechnology and pharma is actually the largest export from Norway today. So we're exporting a total of 26 billion Norwegian kroners each year, and biotech is 70% of that. Medical technology is 25%, but it's truly interesting that here in this audience today we think that there's a huge possibility to do more in that space. So that's interesting. So any comments on that? I don't know.
I think what's interesting is always going to be a challenge for any sort of really major developed economy is to retain innovation. Is that it will? This is the sort of incubator that it emerges from, but then very quickly it goes overseas and is produced and etc. So I think part of that is sort of retaining it, but there are universal challenges, which aging population is specifically one, where the application of this is domestic as well. Yeah. So I think that's an interesting one of how do we retain the value of that.
Absolutely. So follow up to continuing this side. So how do you think that the medical personnel, together with designers, are changing the world? Big question. You can start.
I was more going to follow up what you said on medical devices, how difficult it is to get it on the market. And it's a really long process, taking several steps, all the way from the basic testing of the toxicity, biocompatibility, and the mechanical strength and all that. I can mention a small story from our lab, where an old surgeon, Professor Emeritus Sudman, he had an idea about a new stem hip implant that was going to be more easy to revise. And he got a PhD student, a younger surgeon, and they got in contact with a company in Stavanger who could make these prostheses. They implanted them in goats, so they had to resize them, of course. And the basic idea is, when you do a revision, it's really hard to get it out of the bone. And they had developed an idea where they could actually drill 2 holes on both sides and release the implant from the bone. Okay, so they tested 2 rounds with goats, and it went not so okay the first time. It didn't fasten in the bone at all. So when we did the pull-out test in the lab, they were very loose. Second time, they coated the implants with this bone-friendly material, and it was stuck. You couldn't get it out. Okay, so they found something in between there, and then they went to the industry. There are maybe 5 major companies in the world. So they traveled around and tried to sell this idea. Nobody wanted it, because they said, how can we say to the patients that you will get an implant that will be easy to remove, easy to revise? It's not a selling point. So the whole idea died after, let's say, 10 years of trials. So it's really difficult. So maybe you have to start with a good idea first, or maybe check with the market. Do you really want this product? That was a short experience from my community, at least.
If I can reflect a little bit on this one, just to warn you, because medical technology is a tough one. E-health is huge competition. So if we don't succeed in the process of innovation, then we won't succeed at all. So we need these kind of facilities. We need to start on how we do the process. You can bring whoever you want from academia and tell these stories. It's so many barriers, because the way we do innovation is actually killing innovation. So somebody has to do something about the 6% here. That needs to go up above 50 to solve medical and e-health. That's my saying. Yeah.
I couldn't agree more with you, and it's so amazing to see. I think both the way that you have been working, right? Starting with the people, starting with the process, and starting from there. Maybe you have another,
So we should go to slide on number 2 now.
So I will do that. It's amazing what we can do with technology and process innovation. Okay, so the question here we had, what should we improve to promote health industry export from Western Norway? Because that is another thing, that from these 26 billion that we export today, less than 100 million is from Western Norway. So we really need to do something about that. Interesting. So as a
I would like to address the same question to panelists. So what do you think is the biggest challenge here in Western Norway to actually succeed? So I don't know from where to start. Maybe we should start with Tom, because
I think it's really interesting that sort of frame it so locally. This is obviously this where we are today is a really good symbol of how to do it, right? It's just create community and resource and expertise, and investment's always good and what have you. But there is, and Haukeland is in many ways the hub of it, particularly in aging and what have you. But we invest in health tech at Antti. We work in pharma, and we work in big data tech companies for pharma, and all of them that are Norwegian are everywhere in Norway. I mean, NTNU is super important, as well as University of Bergen, and there's collaboration there, and then so is Oslo. So I don't know. I mean, I think we gotta make a community like this, but it's got to be one that is connected to, not so reductive and small.
So do you have a comment, since you have?
Yeah, I'm kind of divided in my brain, because we love Bergen, and when we started, I was so frustrated. Why is everything happening in Oslo? It's stupid. We have Haukeland, we have the sea, we have the fish, we have the people. Let's do it in Bergen. So I love this. But we met this saying that you have to succeed in your home market before you can go abroad. We don't believe in that. Not at all. The world is pretty small now. It's good to have a solid customer base and kind of success rate in your home market. But it's not, at least our experience, it's not that challenged when you get abroad. How do you succeed home? It's more about how does it work, and what benefit does it create. So for our way, it was do the travels, and we went obviously through the projects. That was our entry into the market. To this saying, cash always. Growth eats cash. And you can't afford to run out of it. So that's the capital side of it. It's a hassle thing, but you have to succeed with that. And always think more than you think you need. It's expensive. Yeah.
Would you want to comment?
Yeah, I think of those on the chart, I think reaching the global market is the big one. I do agree on the other side of the table, because a good idea is nothing worth if the market don't want it. So on Innovation Norway and everything, the first you get money to is market clarification, to see if somebody wants it. And that's why we started. We started pitching the idea to friends and family, and it was easy to catch, because they said, isn't that done? And I said, no, we still do it on the other way in my world. Okay, that's a good idea. Okay, and then it started, and then you need to kind of investigate your idea to see if there is a market and market opportunities, and is it a global market, and could you scale up? The regulatory, the technology, and everything. I think you're gonna get finance on that one if the market's there. So market is the big one, and entry to the market, and that's why this klynge incubator facilities is genius, because when we started on home pages and kind of need to read everything about every funding, every slide. When you come into this, you meet the guys. They tell you need to talk to this guy, then you can talk to me, then you talk to this guy, and then you talk to this guy, and that saves a lot of time. Versus the first question is, 20 years ago, it took 17 years from idea to get to the market. We try to do it on half. In 4 years, I think you can do it in 2 to 3 years, because all the hospital, everything drives these processes.
Very good. Yes, so I think while asking the next question, I will go and turn on the screen again. Someone noticed that is missing. So when we kind of, I think there is a little bit of two different worlds meeting here today. With designers that at least I, coming from academia many years ago, thought it was a little bit scary to ask designers, and I wouldn't work when I did my PhD. I would never dare picking up the phone and start a conversation with a designer. So I'm wondering, are there any good advice? So how would you get started? How would you kind of to start a project with a design agency, where do you start? How much does it cost? Is it are there any ways to kind of lower the barrier to basically just get the ball rolling a little bit? So maybe Tom.
Yeah. So I think the first thing to say is, we. For some agencies, I can't speak for the whole industry, but I would say pretty much that working within health care, pharma, whatever, is unbelievably rewarding. Met somebody, a really interesting company that's moving in here this morning, Caneat, I think they're called, and they said, this is so fantastic, it's really rewarding to work in this space. I mean, this is a ticket into heaven, if you believe in that, right? So the first thing is, I'd be very surprised if any agency doesn't want to talk to you about it. The other thing is, it's ripe for innovation. There are so many things that are the way they are because they've always been that way, but also that it's difficult. It demands regulation. It's a rigorous academic culture of medicine, rightly so. These are things that designers that aren't always good at with sort of the stamina of the same thing that's needed there. So that's kind of an interesting conversation to have. So I think just engaging with those who are very interesting. In Bergen, Eggs Design and Antti are two that are very engaged in this area, and I'm surprised if any others aren't. And attending seminars like this, I think, is sort of part of it. And it's a long journey. Ventisol was 6-7 years, and it's not always on from our design point of view. And so, there's no quick bang for your buck from the design agency point of view. This is about long-term relationships.
Is it allowed to challenge the designers?
Yeah.
Because we have two different experiences that I want to mention. One is that we invited in some designer for a process, and our experience then was that they didn't really take time to understand us. They came with copy-paste from other projects. So what was good at that time was that we knew our product, we knew why we did it and where we wanted to go with it. Because designers or people around you, they can pull in your concept. Sometimes it's a good pull and you need it, and sometimes it's actually a focus thief. It's a wrong direction. And sometimes you're actually fooled and you pay a lot of money for nothing. So know where you want to go. The other experience was good. We needed designers to get further with the product, and they kind of more like listened to us and facilitated the process. They were walking alongside, but we were doing the work, and they just, that was a good. So if there's anyone want to be designer here, listen to your customers. Yeah.
Yes, that's a really good point. A good litmus test, I think.
So can I ask? I think one of the things that kind of caught my attention when seeing your webpage was that it looked very finished.
Yeah.
The kind of product. So it's apparently that you kind of involved designers on a very early.
Yeah, we did, and we're kind of glad to do that. And we like to involve the designers more, but we engage them on an early stage to have sketches, to show the idea, to kind of build around it. We are now in a phase with materials, how to conduct materials to make the solution, to make the product. And if we haven't had the sketches from the designers, we couldn't do the materials. So it's the spiral that you need to kind of get the ball rolling and get them involved. And I don't know it's the right time to do it, but early. As a startup company, you want to do everything at the same time, but you need to choose because otherwise you run out of money, then you're bankrupt. So
So then would you say you'd go incremental steps, design, market, or you still try to do one after
we
the
started
other?
on the market, and we did that as much as we could do ourselves. So we built up surveys, we asked questions, we did interviews by ourselves, and made reports to Innovation Norway and decision makers. And then we kind of saved the technology in the company, because we have 2 engineers and they could do that. The hardware part we kind of exported to Inventas, a big company in Norway. And they did the design things and the hardware solution as well. And then we need to do another market survey. So we are in this moment conducting an international markets analysis by a second company. So we're gonna get that report in the end of September. And then you kind of build it up. And that takes time. And these places kind of, not every day is a smiley day. So you need to kind of see people, talk to other guys that do everything else, because they kind of have the same problem that you have, and they kind of have a solution. And then you go home on a Friday and smile and meet the family, and you start up on Monday again.
Yeah, so
this is really important. We, to ask designers, or actually ask a lot of, what's it called, broader than you actually work, because you don't know if the solution is here or in your scope. You never know where the next good idea, whether it's design or other solution at your product, will come from. And it doesn't follow a title. One of our greatest ideas can come from what's a vaktmester in janitor? The janitor. You never know. So ask a lot of questions way beyond your own product.
I think we have one more slide to end things up, and I just want to repeat. I come from a company called StoneGeo before joining here, that has a kind of a successful startup from Bergen that was recently sold for nearly 4 billion kroners, and we've been working exactly the same way that you did when we scaled internationally. Always working kind of with projects, making sure that we always have cash flow. That is the thing, and also always working with designers and customers. So I think that is we've seen that is a successful recipe to scale globally.
I'd just say one quick thing on that, because you mentioned about agency, and I think that if you look at startup communities outside of health tech, whether it be fintech or prop tech or anything like that, 10 years ago you'd hire a sales and marketing guy. Now it's a designer. So in the first kind of team outside of the founders is generally, because you need to sit on your data, you need to sit on your product, and so you need that in-house. And so it's a kind of combination of who do you hire into the team, as well as what do you outsource. Doing myself out of a job there, but that's
brilliant. So this is brilliant. So 1 to 5 stars. Do you think working with a designer would add value to your work? And you couldn't say no here, can you?
The
leading question. No, but I think it is important to kind of have this in the back of the mind, because it's very often this comes too late in the projects, and then you get the experience that you had, that you kind of your product, and maybe the designer, if it's he is not allowed to work with it and understand the product himself, right? Then it's just not useful for anyone.
Absolutely.
Brilliant. So, are there any questions from the audience before we round up? Yeah.
I just wanted to let people know that we have lowered the threshold for startups to do working with designers by making packages in Norwegian Smartcare Lab. So, if you're in an incubator like this, or in an incubator, you can get quite a good refund as a startup, because Siva is supporting it. So that's a way to start working with a designer. So many of the companies present in Bergen will give you a package there.
Yeah, absolutely. So it's 75%, isn't it? Refund?
It's through Norsk Helsekonsortium.
Yeah.
That's a good one.
Brilliant. Yeah.
So it seems like the commercial model for a lot of these companies is business to business or institution. But you said that you were looking for something in the commercial market.
Yeah.
So I represent Trig with our 450,000 clients in Norway. So I was just wondering, how could we kind of work together in that market?
Oh, hallelujah. Yeah, we can. That's the short answer. We are going to the consumer market, and we know that in some countries, we can go through kind of health, but in, for example, Germany, we need to go through insurance. And I would love to do a coffee and to see if we can do something, because many of the insurance companies kind of look for add-ons to their portfolio, and we can be that. We have a good story. It's a so sure.
Yeah. I also have the prevention of these surgeries. Is that like, what can you do to prevent any of these accidents or replacements? Is there anything you can do?
I would say that the National Registry here in Norway has done a great job. They have been monitoring these implants for more than 30 years, started with hip and expanded to all the other joints. So they are getting feedback from all the surgeons. They get the filled out form from the surgeon telling everything about what happened at the primary surgery. If the patient is being reoperated 10 years later, they get a new form back so they can trace the longevity of each of the products. And if they then detect that some of the products decline, they say to the surgeons every year in a yearly report, maybe not use this product. And then they tell us what was the actual reason why this product failed. So we go to the lab, we get the materials, we look at them, analyze them, and give back our results to the registry people. So it's a very nice collaboration.
Like trying to avoid, or if you say 16,000 surgeries a year, if we could move to, if we can communicate to people that are 30 years, to say that if you do all these things, we can prevent getting into that when you're 65. Is there any work done in this phase? Like, is it possible for me to kind of avoid getting that surgery?
Yeah, that's of course a very good question. I'm not working on that side of it. I'm more on the post-market on the implants. But of course, prevention of these diseases. Obesity is one of the main risk factors for getting arthrosis or damaged joints. And there are other peoples working on that in the medical faculty, choosing the best diets, exercises. We have physiotherapists working on prevention. They are going more and more into research and actually saying to the surgeons that, well, maybe we shouldn't operate this person. Maybe we should use this training program instead. So actually, in one of these randomized clinical trials we are involved in, we put sensors or accelerators on the patients before the operation and in several time points after operation to see if we actually can monitor improvements. But of course, you could maybe monitor the patients a bit earlier than that as well, before the decision for surgery has been made. So there are many things you could do to prevent these things.
If I can show, we are in the lab and we need to work across the silos. Norway is number one worldwide on hip fractures. We are number one in the whole world. It's kind of crazy.
And 30% of them died within the first year after the fracture.
It's really critical. Yes. So if the insurance and academia and Motiview can combine, we can reduce the numbers of hip fractures, and we can increase the speed of rehabilitation afterward if they need it. So we can make a Kinder egg here.
Orthopedic treatment is actually the most expensive treatment among all, more than cancer actually. Well, not so many who knows that actually.
Yeah, it's crazy.
I didn't know.
Brilliant.
They need a bike.
Yeah, they do.
Maybe that's a good thing to go full loop to the first question.
Yeah.
Of like, what are these areas, in the health tech, care tech, pharma tech, all et cetera, et cetera. Actually, it's all about making the bridge between those. And quite a lot of the companies that I come into contact are sort of, are medical tech companies of which are looking at consumer products, because healthcare is pivoting from prevention to care to prevention, right? To prevent that before treatment is needed, which is your point there. And I think that three-way conversation that we just saw right there is maybe how to promote Vestlander.
Absolutely. I'm excited already.
we can call it an Eitri concept, so no problem.
Brilliant. No, so any other questions before we, I guess you can mingle as long as you keep, and maybe if you want to have a look around here, I think most doors are open. Don't steal anything. Then, so if you want to stay a little bit afterwards, that is perfectly fine. Yes?
And we will invite everybody back in December, won't we, Ingrid?
Yeah. Short notice from the side. It's a design festival in the end of November where we will make speed dates, designers, health innovators in Kulturhuset in Bergen. So we'll come a follow-up event where we are more engaging and making different bridges. But maybe we should also make health-to-health bridges as well. Yeah.
Absolutely. Okay, so thank you so much for coming. This is a super nice day. I think it's a good way to travel into the weekend. Okay, thank you so much.